I would like to thank the organizing committee for allowing me the opportunity to be able to speak to you here. So I'll be speaking pretty much about the same things that Fernando did a couple of minutes ago. So I studied 39 eyes having retinal and choroidal tumors. 27 patients had treatment-naive tumors and 12 had choroidal tumors after treatment. And all the studies were performed using the Triton Plus Web Source OCT device. I would like to show you some examples now. This is a patient with choroidal nevus in the right eye. You can see the choroidal nevus along the inferotemporal arcade. And this patient also had asteroid hyalosis. And this is the Web Source OCT image showing the tumor nicely, despite the presence of vitreous opacities. And here you can see the characteristic features of nevus, including choroidal shadowing, choroid capillaris compression, ellipsoid zone irregularity, and photoreceptor loss. These are all signs of chronicity. So, and this is the OCTA image. So this is the screenshot from the Triton device. Here you can see the superficial plexus. This is the deep plexus. This is the outer retina, and this is the choroid capillaris layer. And this patient had a hyperreflective network in the choroid capillaris layer, and no changes in the other retinal layers. So this is another patient with, again, choroidal nevus. This is the left eye, and this patient had this lesion along the inferotemporal arcade. As you can see here, there are lots of drusen on the lesion surface. And this is the fundus autofluorescence image showing tiny pinpoint hyperfluorescence on the lesion. And this is the Web Source OCT image. Basically, it shows the same features as discussed in the previous patient. But this patient also has drusenoid retinal pigment epithelial detachments, which also is a sign of chronicity. And this is the OCTA image of the same patient. Again, we see no change in the superficial, no change in the superficial retina, deep retina and outer retina, and basically in the choroid capillaris layer, there is a hyperreflective change, a network this time. Summing up the OCTA findings in choroidal nevus, the retinal layers are usually not involved, and the major change is in choroid capillaris. Tumor manifests as hyperreflective to hyperreflective change, and extensive drusen and fibrosis on the tumor surface may lead to vascular disruption and a hyperreflective change, as in our first case, and this finding has been reported before by Toledo and associates. And choroidal images are variable and may vary between different OCTA platforms, and there was no change in choroid capillaris in patients with choroidal nevus in a prior publication by Gennamo and associates. So choroidal melanoma is next. We are able to image only small choroidal melanomas with OCT and OCTA because of segmentation and out-of-range errors. And here you can see a small melanoma located next to the fovea. And this is the fundus autofluorescence image showing the patchy hyper-autofluorescence on the tumor surface. And this is the B-mode ultrasonogram showing a 3 millimeter thick lesion. There's some acoustic hollowness within the lesion. And this is the Web Source OCT image. Here you can see the ascending loop of the tumor. Again, we were unable to image the entire lesion because of out-of-range artifacts, but here on the ascending loop you can see choroid capillaris compression similar to choroidal nevi. And this is the OCTA image. Again, we were unable to image the lesion in its entirety because of out-of-range errors. And this time, there are changes in the outer retina as well. Here you can see a hyperreflective network in the outer retina and choroid capillaris layer. And so this is different than choroidal nevi. Choroidal nevi usually don't have any changes in the outer retina. So this is a suspicious choroidal melanocytic lesion located inferotemporal to the optic disc, as you can see here. there's extensive subretinal fluid. So based on the presence of risk factors, including vision loss, subretinal fluid, lipofuscin, and close location to the optic disc, we consider this as an early choroidal melanoma. And this is the autofluorescence image showing the hyperautofluorescent subretinal fluid and the lipofuscin on the tumor surface, again giving a hyperautofluorescent image. And this is the swept source OCT. Here we can see a gentle round contour to the tumor. There is choroid shadowing and choriocapillaris compression similar to choroidal nevi. And this patient had subretinal fluid, and as you can see here, and there are also photoreceptor clumps or shaggy photoreceptors on the retinal surface. And on OCTA, this lesion had similar features to the previous melanoma patient. Basically, there was a hyperreflective network in the outer retina and choriocapillaris layer. Here you can see some shadowing from the subretinal fluid in the deep retina layer. So in summary, choroidal melanoma usually manifests as a hyperreflective network in the outer retina and choriocapillaris, and there are no changes in the superficial retina and deep retinal layers. Choroidal hemangioma is also a common intraocular tumor, benign tumor in adults. Here you can see a hemangioma, orange-shaped tumor located superior to the optic nerve. And this is autofluorescence imaging showing that the lesion is mostly hypoautofluorescent. There are also some changes here from prior subretinal fluid, I presume. And this is the OCT image. This is a 6 millimeter image showing nicely the tumor details. Basically, in contrast to nevi and melanomas, there is no choriocapillaris compression in this type of tumor, and further expansion of medium and large-sized choroidal vessels. Again, you can see a smooth dome-shaped contour to the tumor similar to many choroidal melanomas. And this particular patient had extensive intraretinal schisis over the tumor and some minor subretinal fluid as well. And this is the OCTA image. Basically, the superficial retina, deep retina, and outer retina are unaffected, as you can see here. And when you increase the choriocapillaris slab to see the choroidal tumor, you can see the interconnected intratumoral vessels here nicely. So this is another patient with choroidal hemangioma. So this tumor was a little thicker. It measured about 2.9 millimeters in thickness. And this is the OCT image of the same patient showing the same features, but this patient also has some retinal pigment epithelial atrophy beneath the subretinal fluid. And this is the OCTA image, this time showing some changes in the outer retina in addition to the choroid layer. So this is not the same as the previous choroidal hemangioma patient, which didn't have any changes in the outer retina. So this is again a finding we see in some thick choroidal hemangiomas. So summing up the OCTA findings in choroidal hemangioma, the retinal layers are usually not involved. Major change is in choriocapillaris and choroid. Multiple dilated interconnected tumor vessels intermixed with connective tissue, which is actually the tumor stroma, are seen, and probably the tumor stroma is showing up as single void areas, as Dr. Fernando previously mentioned. Interestingly, choroidal hemangiomas more than 2 millimeters in thickness may have outer retina involvement as well. This may be due to a compressive effect, atrophy of the retinal pigment epithelium, and maybe some choriocapillaris, which makes the tumor vessels visible in the outer retina as well. Retinal tumors are rare compared to uveal tumors in adults, and here we can see a patient with retinal astrocytic hamartoma. This is the left eye. You can see the whitish colored lesion, and this is the beam mode ultrasonogram showing a 1.8 millimeter thick lesion with some intrinsic calcification. And this is the swept source OCT image showing probably a type 3 associated hamartoma by the Peachy classification. And basically you see some focal vitreoretinal traction, choroidal shadowing from calcium, and optically empty cavities within the lesion. This lesion originates from retinal nerve fiber layer, and this is easily seen on OCT cuts in smaller tumors. And this is the OCTA image of the same patient. This time we have a vascular network in the deep retina and some vascularity in the superficial retina. And probably there's a masking effect on the outer retina and choroid capillaris, either from high blood flow within this lesion or maybe calcium deposits within the lesion. And here you can see the optically empty cavities or cysts within the lesion, and these show up as non-flow areas in the OCTA cuts. So I already talked about this slide. And finally, I would like to show a few examples for changes after treatment. This is a patient with choroidal melanoma treated with transpupillary thermotherapy. This lesion was located outside the fovea, and we chose to treat it with TTT, 3 sessions, spaced 3 months apart. And this is the autofluorescence imaging after treatment. Basically, you see a hypoautofluorescent inactive lesion. Again, some changes from prior subretinal fluid. And this is the swept source OCT showing atrophic inner retinal layers from transpupillary thermotherapy application. And there's increased visibility of the increased transmission of light because of RPE atrophy induced by the treatment. And this is the OCT A showing retinal non-perfusion, probably from TTT treatment. And here you can see probably choroidal vessels or intratumoral vessels from RPE atrophy, choriocapillaris atrophy. So there is increased visibility of the tumoral vessels after treatment. And so this effect I have also seen in choroidal hemangiomas, the increased visibility of choroidal vessels. This is not shown here due to time restrictions. And this has also been reported after laser photocoagulation of choroidal hemangioma by Dr. Chawla recently. And one final case, this is a patient with choroidal melanomas treated with stereotactic radiosurgery, which was cyberknife radiosurgery in this case. This treatment, I believe, is not done in the United States. It's more popular in some centers in Europe. So you can see the nicely regressed tumor. There is no sign of abrupt radiation retinopathy or maculopathy. But on OCT, we see evidence of widespread non-perfusion. This is next to around the optic nerve area. OCTA helps us to see radiation changes in the macula better in a non-invasive way. In conclusion, OCT and OCTA have become instrumental tools in ocular oncology to assess changes over the tumor and in the macula before and after treatment. They are also important in the diagnosis and follow-up of radiation maculopathy. Best results are obtained in tumors less than 3 mm in thickness and small base diameter and posterior pole location. And I would say best results are obtained in tumors less than 2 mm in thickness, because in this up to 3 mm, you can still have some out-of-range artifacts and segmentation problems. OCTA definitely takes a longer time compared to standard OCT to acquire images, and it requires patient fixation. This is important, and better technician skills. And one final word, different machines may vary on their ability to acquire thicker tumors at different locations. This is an astonishing paper by Pellegrini which was published in the journal Retina last year. And here you can see that tumor almost 8.5 mm in thickness being nicely shown on an OCTA platform. So I think the future of OCTA technology should be in the way of getting better images, clean images without segmentation errors, and in maybe thicker lesions compared to what we can get at this point. Thank you very much for your attention.